G'day, I'm Ted Jedinag, podiatrist and international educator of health practitioners in manual therapies, helping you get even better results, clinically and commercially. And I've got a great gift for you today, especially if you're a podiatrist and you want to become more focused on MSK treatments or manual therapies. Like, how do you actually do that? How do you develop an interest in manual therapies when at this stage in our undergraduate courses, it's not a big part of our training? Well, I've got a grand guest for you today, David Cashley from the UK. He has travelled that path of graduating as a podiatrist and then developing a high level of expertise and skills in manual therapies and focusing on MSK conditions. So, David, thank you very much for taking my call.
Hi, Ted. Thanks for having us.
Yeah, it's my pleasure indeed. Now, at this stage, David's going to share with you his journey, and we're going to start at the beginning. Literally, David, how did you get into podiatry in the first place?
Well, Ted, as a kid, we had a long bus journey to school, and my mum and dad would set me on the bus in the care of this really nice old lady. Well, she was old to me because I was like 10, and she was the nicest person I'd ever met. Mm-hmm. She looked after me, made sure I was sound on that journey to school every morning, and she was a podiatrist. So I had decided in my head at that stage that, you know, podiatrists are nice people, and I'm going to have a look at that. Mm-hmm. Further on in my education, I came across that quote from Da Vinci about the foot being the most remarkable feat of engineering on the planet, and that really nailed it for me. I thought if it's good enough for Da Vinci, it's good enough for me. So I'm going to have a look at this as a career.
Ah, well done. And so, when did you graduate, Dave?
So I graduated from Queen Margaret University here in sunny Edinburgh, not quite as sunny as Adelaide, but there you go. And I graduated in 1997.
Ah, wonderful.
Seems forever ago, Ted.
Well, it was last millennium, so yeah, I guess we could. We're both of that vintage. Oh, terrific. So, David, how did you? What in your typical week? What portion of your working week is focused on musculoskeletal conditions and treatments?
Well, my working week is split in two, exactly half and half in private practice and half working here for the Ministry of Defence. So the Ministry of Defence element, that's 100% musculoskeletal. Okay. And in my own private practice, probably 2/3 musculoskeletal. So overall, my maths is not great, but probably 80-85% of my work's musculoskeletal, and the other portion routine clinical work.
Okay, terrific. So when you first graduated, Dave, how did you develop the interest, or how did you become involved in MSK focused practice?
Well, Ted, my first clinic was, I went straight into private practice when I graduated in 97, and I opened my first clinic in a chiropractic clinic. Oh, okay. Along with my brother Mark, who's a chiropractor. And we basically teamed up with the idea that the two professions really complement each other very nicely, and he could do the manipulation and looking at those areas, and I would work on the orthotic prescription and the biomechanics and these kind of things. But early on, I came across a patient who had dorsal navicular pain, and I'd done all the things that I'd learned at college, and I was pretty green still and not terribly experienced. I didn't get good results with this particular patient, and it became very frustrating. So we decided to have a look together, the chiropractor and I, and he came in, he adjusted the foot, and we got instantaneous relief. And the patient wasn't fixed by any means, but just the fact that we'd made an immediate breakthrough when I'd been trying for weeks and weeks, that just captured my imagination. That was really exciting and something I wanted to know more about, because it looked like a really potentially powerful treatment option. So from that point, it cooked.
Wonderful. Now, Dave, you've used this term, adjusted the foot. Now, what does that mean?
Okay, it's probably really a chiropractic term, and we might just say manipulated the foot, but the chiropractor looks on the adjustment as the actual process of the manipulation. So yeah, we should probably just say manipulated the foot.
Okay, so yes, he performed a high velocity manipulation.
High velocity.
Yep. Okay, good.
But all of the manipulations that I personally do, it is high velocity, low amplitude manipulations. Yes. So
okay, great. So now for all the listeners, I just want to give you a little bit of background here, where in earlier this year, in the May edition of the UK journal Podiatry Now, there was an MSK Focus edition, and one of the questions that I will commonly get asked from practitioners who are exploring manual therapies in podiatry is typically, where's the research? Now, Dave, do you ever get asked that question when you talk or teach about manual therapies?
It's so frustrating, Ted, because it's the one thing that comes up all the time. It's like, and you're not so much asked where's the evidence. You're more kind of told there isn't any, and that's really frustrating. It's like, oh, it's all voodoo. There isn't any evidence, and that's just so wide of the mark. There's huge amounts of evidence out there in favour of extremity manipulation. And in that article you referred to, I think I listed about 50 papers that all point to the evidence of the efficacy of manipulation. So it's a frustrating question to still be getting asked kind of 20 years down the line. But at the same time, the answer's at our fingertips. That there is good evidence out there. We just need to avail ourselves of it.
Yeah, and I absolutely agree with you. I've just got to correct you on one thing in relation to your references there, Dave. There are actually 52 references, not 50. So, I'm going to keep you on your toes here.
Thanks for that.
Yeah, and it's great because I've appreciated the article and yes, the depth that you covered with that, and yes, the incredible list of references there. And for listeners, I will certainly make a copy of that article available, because it's been a regular attachment to emails that I still get asking about, yes, where's the evidence? And the fact is, physiotherapy, chiropractic, osteopathy, they have been using manual therapies for decades, and my approach has typically been, well, if it works on the spine or if it works on the shoulder, we've still got the same anatomical ingredients in the foot, ankle and leg. Why wouldn't it work there as well? And I understand that the type of research and what the evidence for specific I suppose pathological conditions that are treated. I'm going to leave that to the academics, because it's not my strong point. But I know both anecdotally and evidence-based, there's plenty of evidence that supports the use of manual therapies for the lower limb. Okay, so let's use almost like a bit of a case study. If you've got someone coming in describing or complaining of symptoms consistent with Morton's neuroma, how do you go about your initial assessment evaluation in preparing a treatment plan?
Okay, well, what I like to do, initially I'm going to confirm that diagnosis, and I tend to do that with two very simple tests, the squeeze test or the Mulder's click test,
yes,
and I combine that with the plantar digital nerve stretch test.
Can you, now, given this is an audio production here, can you please describe those tests?
Yeah, well, the squeeze test is pretty self-explanatory. You take the foot and you squeeze it. If you apply pressure medially and laterally with each of your hands, compressing the metatarsals from medial and lateral,
yes,
you should be able to elicit the symptoms of the neuroma. Now, if you get a palpable click when you do that test, that's what Mulder originally described, and that's the Mulder's squeeze and Mulder's click test.
Yes.
But there's a few papers that suggest actually just eliciting the symptoms, even without the click, is a positive indicator of the presence of a neuroma. So I don't feel the need to get that palpable click. We just need to get that re-elicitation of symptomology.
Okay.
That on its own is not specific for Morton's neuroma. You know, we could be irritating a bursitis or a capsulitis or something like that for sure.
Okay.
That's why I combine it with a second test. And the plantar digital nerve stretch test is just as it says, we're stretching the plantar digital nerve. So what I do is I take the two toes either side of the affected cleft.
Yes.
And maximally dorsiflex the ankle, then we maximally dorsiflex those toes. And we do that on both sides, the asymptomatic side and the symptomatic side.
Okay.
And again, we should get a very definite pain on the symptomatic side with no pain on the asymptomatic side. Okay. And the interesting thing about these two tests, and the reason I use them, is that there's a couple of fantastic papers, one by Pastides et al. And one by Sharp et al. And what they did was they looked at clinical tests versus radiological tests for Morton's neuroma specifically. And both of these papers independently found that combining two clinical tests, and I think it was Pastides that said specifically those two tests were the most accurate, but combining those two tests for Morton's neuroma, sorry, I should go back a little bit and say that the way their study was designed was that they did the clinical tests, they did ultrasound, and they did MRI.
Okay.
Then they operated on the neuroma and sent the neuroma for a histological exam. So we've got a histological report on the existence of a neuroma in these particular papers. Okay. So what they concluded was that actually these two tests were more accurate than ultrasound, were more accurate and sensitive than MRI, and in fact were more accurate and sensitive than ultrasound and MRI combined. You know?
Right.
So sometimes we overlook the value of a clinical test and we go straight to those, radiological tests, and we look for big fancy expensive machines to do the job, and our hands are the best tool we've got, and here we've got some really quite good quality research that says the clinical diagnosis of a Morton's neuroma is as good, if not better, than the radiological. In fact, no, I'll be a bit stronger than that. I'll say the clinical diagnosis of a Morton's neuroma is better than the radiological diagnosis of a Morton's neuroma. Okay. So, when I get one in the clinic, I'm really confident with that diagnosis because of their research. So that's where I start.
Terrific.
Getting that diagnosis right.
Okay. Now, just before you progress on there, Dave, you mentioned about the plantar digital stress, the nerve stress test. When you do that test, do you combine that with the squeeze test, or is it just the pure digital nerve stress that elicits the symptoms?
Yeah, it's just the stress. So the two tests are separate.
Okay.
They're done separately. So just the stretching of the nerve that irritates the affected nervous tissue. Okay,
great. All right, that's a good distinction. Thank you. All right, so you get a positive clinical test result, rather. Then what? What's your typical treatment approach? How would you take care of that person?
Okay, so the first thing I want to do next, which is not terribly commonly done, but I do it because as the treatment progresses, it gives me confidence that we're going in the right direction. So I like to use a measurement tool called a pressure threshold meter. And what that does is it lets you know how much pressure a joint can withstand before it registers pain. And the logic there being that a joint that's dysfunctional, a joint that's struggling, will register less pressure before it becomes painful. Okay. So what you often find is if I run my little pressure meter, and you can get these pressure meters really easily, they're I don't know what the exchange rate would be, but over here they're maybe £80, £90. Okay. So not an expensive bit of kit. And you can very easily identify which of the, for example, in this case, I'd be looking at the metatarsophalangeal joints and seeing how much stress they can take. And very often you will find one of those joints takes considerably less stress than the others before it registers pain.
Okay.
And I like that because we have then a kind of hard outcome. We have a very definite numerical measure. This joint took 2 newtons of pressure or whatever before it registered pain. So as we treat, we can keep checking and see that number climb and becoming normalized alongside its neighbors or alongside the contralateral limb. So that's quite exciting for me. I like to use that tool. It gives me a very definite guide as to how things are progressing. So that's the very next thing I would do, is take that pressure reading. You can substitute that. You can use something like a VAS scale and ask the patient about their general pain level. But VAS is a bit messier, I think. This is very definitely about this particular joint and how much stress it can take, and I like that. But it's good to have a measure and outcome, so I tend to take that at this level.
All right. Now, Dave, just
sorry,
just before you progress, I'm not familiar with the pressure threshold meter that you've identified. Is this something that, are you happy with inter-tester reliability and just the repeatability of results?
Yeah, repeatability and inter-tester reliability is very good, very high. Fisher, back in, I think, late 70s, early 80s, he did some pressure analysis on the spine using this pressure threshold meter, and he was probably the first to use it. There's been a lot of studies done on it since, just looking at exactly that, inter and intra-rater reliabilities and repeatability, and it scores very, very favourably. It comes out really quite nicely. So we've actually just recently published a paper on the reliability of this meter as well. So yeah, I'm really confident that it's a sound tool. Very simple to use. Doesn't take much in the way of expertise or training. So even in novice hands. In fact, there's a couple of articles specifically looking at the tool in novice hands. And it's great. It works really well. So a good tool. And like I say, inexpensive, nice, simple bit of kit to bring to clinic.
Terrific. I'm going to trouble you for a link to where this can be available, so that anyone who want to get hold of that, we'll make sure we include that in the attached email here. Terrific. Okay, so you've done your clinical tests, you've taken your threshold meter readings. What's next? Where do we go now?
Okay, well, it's interesting. With Morton's neuroma, a lot of people talk about it being related to a pronated foot and mechanical overloads. And I can honestly say, in my coming up for 20 years, I really haven't seen that. I see Morton's neuroma in a whole host of different mechanical entities. I have seen it, in a grossly pronated foot, in the adult acquired flat foot, But I've also seen it in a cavus foot, and I think quite a lot of times its onset is more related to workwear or shoe gear or standing all day at work. I'm not sure that it really is strictly a biomechanical entity. So certainly I will still perform a biomechanical assessment and we'll look for those problems. But I quite often find that they're not there with Morton's neuroma. If they are there, I'm certainly going to, look to correct anything that's there. So we will, of course, look at orthotic therapy or anything like that. But as I say, they're often not there. So my next step is going to be to chat with the patient about what the various options are, maybe because of their work style. We're close to Aberdeen here with a lot of guys out on the rigs, and it may be that he's heading off for work for 4 weeks. He's not going to be back in that time, and we might want to talk about footwear while he's away or steroid injections and all these kind of things. But my go-to treatment for Morton's neuroma is absolutely manipulation where it's indicated and where it's going to fit with that patient's lifestyle. But that would be my go-to treatment.
Okay. So what are your objectives? What are you trying to achieve with the high velocity manipulations that leads to, and why is it your preferred treatment option?
Okay, so what I'm looking to do, there's a couple of theories about the etiology of Morton's neuroma, and one is that it's a nerve entrapment. When Morton first described it, he suggested it was a nerve entrapment at the met head.
Yes.
Subsequent studies have suggested it may be a nerve entrapment by the deep transverse intermetatarsal ligament.
Yes.
Regardless of which of those is entrapping it, the manipulation makes sense because we're stretching that soft tissue, we're stretching the neural tissue, and we're increasing the range of motion at the joint. Uh-huh. In my personal opinion, I'm not convinced by the entrapment theory under the ligament. I don't think that holds up to scrutiny when we look at the actual imaging of where the neuromas tend to sit, because they tend to be quite a way distal from the ligament. So I'm not convinced that the ligament is directly impinging, although it certainly can restrict the amount of available room in that compartment for the neuroma.
Yes.
So my goal with the manipulation is basically to take those potential irritants out of the equation. So if we have tight ligament structures, then we're going to stretch them, open up the joint, get things moving a little bit more freely, get less irritation going on around that joint. Yes. So the immediate goal is to increase ranges of motion.
Okay. Just from a personal perspective, when you do the manipulative work in the forefoot area, how often would you actually irritate or cause more pain? Because I'm imagining if there's a sensitive nerve or neural tissue here, and you start applying some high velocity forces, what's the chances of actually making things worse?
Well, I can honestly say I've never had anything be made worse in the medium to long term. Mm-hmm. Occasionally, at the point of treatment, you can certainly get some pretty serious discomfort. That's true. Mm-hmm. And obviously, it's incumbent on you as the practitioner to prepare your patient for the fact, this is going to be momentarily unpleasant. Having said that, 90% of the time with a neuroma, they step down off your plinth. Mm-hmm. They're immediately more comfortable. Mm. So, it's a trade-off. You're going to get a little bit of discomfort here, but you're going to get immediate relief from your neuroma. Yes. And in my experience, most neuroma sufferers are going to take that every time.
Yeah, great. And typically, Dave, how long would a treatment plan go for? If someone wasn't heading off onto the rigs, if they were going to be available, what would your typical treatment plan consist of then, as far as number of treatments and length of time that you would expect to be working with them?
Okay, as a classic example, would probably be 6 treatments. Uh-huh. And initially we would do them, there's some flexibility in the first instance, depending on just how painful we are and how tight the foot is and how much resistance there is to your efforts to get things moving.
Yes.
So I would see them anything from once a week initially, mm-hmm. right down to every couple of days. So I might see them 2 or 3 times in that first week just to get things moving.
Okay.
Once we've achieved that, I would say we're going to be weekly for probably 3 to 4 weeks in total, or 3 to 4 treatments, I should say, mm-hmm. and then fortnightly for a couple more beyond that. Once we get into that kind of 6 treatment ballpark, we're beginning to see some medium-term stability. So we're starting to be pain-free for weeks rather than hours or days like we would be initially. Yes. Going back to that first treatment, I'll normally tell the patient, you're going to be pain-free and it's going to be great. It's quite often, it's the first time they've been pain-free for a couple of years or whatever,
Yes.
And by the time you get home, your pain relief's going to be gone. You're going to be back to square one. Okay, so you're going to get an hour or 2 where it felt great, and then things are just going to tighten up because they've been that way for so long.
Yes.
So, and each time that we manipulate it, you can expect to get that pain-free period back, and it becomes progressively more stable. Okay. So you're going to go from an hour or 2 to half a day and then a couple of days, and then we're going to start to get into looking at being pain-free for a week and a fortnight, and it's going to slowly build that way. Mm-hmm. So around about a 6 treatment phase, I would expect someone to be being pain-free for a week or 2 at a time.
Okay.
At that point, I tend to then say to them, okay, what we're going to do from here on in is you're going to come and see me as soon as you get sore. So if you're going to get 2 weeks benefit, I don't want to be manipulating you in a week's time. So as soon as you're sore, you come in and see me. And what we'll find is that period of pain relief just continues to grow, and those weeks become months. By the time you're at 8 or 9 treatments, I would say, that patient's getting no pain and no recurrence of pain. Now, what we don't know at this stage, in terms of our strict research,
yes,
is whether that neuroma recurs. I can tell you anecdotally from my clinic that I think once you're stable, you're stable.
Yes.
Okay, but we don't have any evidence for that at the moment, and that's really what the research I'm doing is based on, finding out what happens long term and how does the neuroma that's treated with manipulation behave as compared to the neuroma treated with a steroid.
Okay, great.
But that's research. So.
Nice. And so that's a project that you're involved with, you're actively involved with now?
Yeah. I'm doing a randomized controlled trial at the moment where we're comparing a group of 32 neuroma sufferers who have had a steroid injection with 32 neuroma sufferers who have had a course of manipulation. And what we're looking to do, there's a couple of things we're doing, which is quite interesting. We're using an F-scan walkway, and we're looking at pre and post manipulation changes. So what changes in terms of pressure, load, and time integrals when you manipulate.
Yes.
But much more importantly, from my point of view, we're looking at, does manipulation outperform steroid as a conservative treatment for Morton's neuroma, I should say, a non-operative treatment for Morton's neuroma.
Sure.
And it's early days yet. We've only been running for a year, and we've probably got about another 18 months to run because we want to follow people for quite some time and see how long those periods of relief last. Because we know with the steroid, people get, depending on what you read, somewhere between 3 months and 9 months of relief, and that's really as good as it gets. What I'm hoping with the manipulation is that what I see in clinic is borne out in the reality of the a more rigorous investigation, if you like. And so hopefully we're going to follow people for 18 months or so and see that neuroma stays settled for that length of time.
Oh, that's very exciting. I really look forward to hearing how the results of that go. But that's a great comparison to be able to compare the steroid and I suppose, yes, as a non-surgical options, the use of steroid as an intervention, or the use of manual therapies. Oh, fantastic. So, Dave, if I can help you cast your mind back some close to 20 years now, your development of your palpation skills, the development of your manual therapy skills. Can you remember what happened back then? Like, did you ever find that you got frustrated or that things you couldn't feel what the chiropractors were feeling? What happened way back then?
It took a while, Ted. It took a while.
Well, how long's a while? How long did it take for you to go, hey, maybe I am actually getting this gig together?
Well, the way the chiropractor who was working with me, he was very, very patient, and he started me off with manipulations just of the lesser MTPJs, and that was nice because that's an area to get grips of quite quickly, and so I could feel some restrictions and things right from early days.
Okay.
I also missed a lot, but I could feel enough to say, yeah, okay, I get what I'm supposed to be looking for here.
Yes.
But I would say it took me, my palpation skills, probably about 6 months of constant use every day before I got to the point where I thought, okay, I'm confidently picking up everything that I should be here. And
Okay.
The palpation skills wasn't such a problem in the early stages, but the manipulation skills were. Quite often I was feeling, I should be manipulating this, and I just couldn't make it happen, or I wasn't convinced that it happened. I hadn't had cavitation, or I hadn't had any evidence in terms of feedback from the patient that this had improved.
Okay.
And that was probably especially true when I got into the mid-tarsal of the foot, and it's really just some small joints in there. My big clumsy rugby playing hands couldn't get in there, and so there's a wee bit of frustration certainly in the early days, but it's all about practice, isn't it?
So what advice would you give to a new graduate, Dave, when you were trying to develop your skills, or what advice did your chiropractic colleague give you to help develop your skills?
Okay, my advice would be palpate every foot. If someone comes into your clinic for a nail cut, palpate every joint. Get to know what normal feels like.
Yes.
Because when you know what normal feels like, the abnormal jumps out. So just take your time. Every foot's an opportunity to learn a little. So, doesn't matter what they're in the clinic for, go through those ranges and quality of motion movements and check them out and compare them to the contralateral side. Just take some time to educate yourself with every patient. So be thorough. Yes. Be thorough. Check every joint. Check your own technique. What are you doing when you're palpating? Are you pressing really hard? Because you're gonna desensitize your fingers if you're pressing really hard. So yes. Keep your touch light. Check yourself out and investigate the small things.
That is spectacular advice, and something that I wholeheartedly support. For the graduates of my training programs, that's one of the first things I will advise. It's like, no matter what people come in for, practice on each and every one. And one of the great scripts that I developed was if I was doing a general treatment, and just once I'd finish, I'd say to the patient, look, just to make sure I haven't missed anything, do you mind if I just go through and check each of the joints in your foot? And everyone would always say yes, because who wants to say, no, I don't care if you've missed anything, let me go. It's
a value-added treatment for the patient, because you're checking that everything's sound. And while it's useful for you, it's useful for them too.
Most certainly. It's a win-win situation, definitely. Oh, look, this is fantastic, Dave. I really appreciate you. The listeners won't realise this, but this is your Sunday morning. So I want to say a big, wholehearted thank you for being willing to give of your time. You've covered some terrific points, and if I can just summarise some of the key takeaways that I've noted from this. First one being the studies that show the clinical diagnostic tests are more accurate or more reliable than ultrasound and the MRI diagnostic imaging. Second one is our hands are our best tools, and unfortunately as podiatrists we don't get a lot of that in our undergraduate training, but it's a skill, and any skill is something that it can be learned and developed. So that's a great point there. And also your observation that neuromas don't form consistently with biomechanical morphologies, and making sure that we've got a comprehensive coverage of, is it footwear, is it work activities? If there was if people were only going to do one thing as a result of listening to you, Dave, I would put it in as palpate every foot. Like, just force yourself or discipline yourself to develop your hands-on skills, because the rewards for you as a practitioner are great, but also for your clients, your patients, they certainly, it would be a very good thing to persist with. So they were my final points. Do you have anything in conclusion, Dave, that you would like to say, share, or impart to the FMT Tribe listeners?
Yeah, I think I do. Yeah, sometimes I think we want to get a little bit deeper into the neurology, I think, to give ourselves confidence about what we're doing. And maybe actually, Ted, that's a chat we can have another time about the actual neurology of what's happening when you manipulate, because that's a fascinating area, and it gives you confidence about the impact you're actually having in the foot. But we looked at what I would say to my younger self, and I think I'd be keen to give my older self a message as well, because there's a lot of us out there pushing 45, 50 now, and I think the important thing now in my stage in the career is to stay enthusiastic and be open to new ideas, and especially in the manual therapy world, there's some crazy things out there, but there's some great things out there as well, and just try and take these all on board and keep yourself enthusiastic about the patients you see and the impact you can make in people's lives. So that would be me.
Oh, nice, lovely. That is a wonderful sentiment and a wonderful experienced voice to impart to our listeners. Now, I have got one final thing, and that is, Dave, I'm definitely going to be taking you up on a follow-up interview in relation to the neurology of manipulative techniques. That is great.
That was great.
Excellent. We'll certainly tee that up and let our tribe know when we'll have that one available. All right, I'm going to let you loose for now, Dave. Thank you very much for your contributions and your generosity, Dave. That really is greatly appreciated. I will include the links that we've covered so that everyone has access to the relevant points that we've covered here. But Dave, thank you very much on behalf of all the FMT tribe. Really appreciate that. Thank you.
Cheers now. Bye.
Cheers.